In this video, we'll talk about the atrioventricular reentry tachycardia, which is AVRT. This is a distinct form of SVT that has nothing to do with the AVNRT, atrioventricular nodal reentry tachycardia. Okay, to start with the AVRT, it is actually a form of paroxysmal SVT, and it actually happens in patients who are having an accessory pathway. Usually it's called bundle of Kent that is seen with patients with a syndrome called Wolff-Parkinson-White syndrome. Okay, so they will have an accessory pathway connecting the atria to the ventricles. This is called accessory pathway or bundle of Kent. Okay, now because of this accessory pathway, a new form of re-entry circuit can happen between the AV node and this accessory pathway. And the ECG features will actually depend on how the electricity is traveling. Is it going through the AV node, then the accessory pathway, or vice versa? So actually, we have two types of AVRT, either orthodromic or antidromic. Let's talk about both of them. Now, let's imagine that we have an SA node here that is giving me the electricity, generating the electricity. Normally speaking, this electricity will go first to the AV node. The AV node will delay it a little bit, and after that, transmit it to the ventricles through the bundle of Hess and Purkinje and all the bundle branches. And because of this electricity, the QRS complex will be narrow because this is a fast pathway for conducting electricity. Now, what happens in the AVRT, and let's talk about the orthodromic, which is the most common type of the AVRT. Now, this electricity will go through the AV node first and goes to the ventricle. So it will produce a narrow complex, a QRS complex, narrow complex form of the QRS complex. And after that, this electricity will retrogradely go back to the atria, giving me a new P wave, a retrograde P wave after the QRS complex, okay? And this electricity will go back into the AV node, going down, giving me another QRS complex, going up again, and retrogradely to the atria, give the retrograde P wave, and so on. So there is a re-entry circuit or phenomena. This is called orthodromic because ortho means normal, meaning that the electricity normally, initially, followed the normal pathway through the AV node down. So in orthodromic tachycardia, the electricity is following the normal physiology, going through the AV node to the ventricles. And only after that, the electricity will go back from the ventricles to the atrium through the accessory pathway. Okay, this is called orthodromic tachycardia. Okay, what about the antidromic one? The antidromic is just the opposite of this. The electricity, instead of going through the AV node first, let's say like an ectomic beat or like a premature atrial contraction happens, and this electricity first reach the bundle of Kent. This electricity will go to the ventricles first. And because this electricity reached the ventricles through the accessory pathway, this is an abnormal pathway. It is a slow pathway because it's not connected to the normal pathway of the normal circuit of the heart. So it will travel slowly in the heart and give us 100% a wide complex, QRS complexes, okay? It will give us a wide QRS complexes. All right. And this electricity first reached the ventricles through the bundle of Kent. And after that, this electricity will go back through the AV node back into the atria, okay, giving the retrograde P wave. But if you can see here, the conduction to the ventricles happened on the opposite direction. First through bundle of Kent, giving a wide complex, and after that, retrogradely through the AV node. This is called antidromic. And actually, this is very rare type. And because of this is a wide complex tachycardia, it is almost always confused with VTAC, ventricular tachycardia. And we treat them most likely the same. And if you are in doubt what rhythm the patient is having, just assume ventricular tachycardia because that one can kill a patient. All right, so again, we talked about the two types of the AVRTs. It's orthodromic, in which the anterograde conduction is happening through the AV node, the anterograde to the ventricles. While in the antidromic, the retrograde conduction is happening through the AV node. Okay, so the anterograde is happening through the accessory pathway, and the retrograde is happening through the AV node. Okay, again, in the orthodromic AVRT, the anterograde conduction is happening through the AV node, producing a regular narrow complex tachycardia. Regular narrow complex tachycardia. But this is not always, because the patient can have a pre-existing a bundle branch block, aberrancy, or whatever in the heart, making all the Kear's complexes wide. Okay, so it's not the rule that always the orthodromic AVRT is narrow complex. It could be a wide complex, just like any other supraventricular tachycardias. While in the antidromic AVRT, in which the anterograde conduction is happening through the bundle of Kant, this will produce a regular wide complex tachycardia, and this is almost always difficult to distinguish from the ventricular tachycardia. Okay, and the trigger also is just like premature atrial or premature ventricular beats that can produce both. Okay, let's talk now about the orthodromic AVRT. We talked about this, the orthodromic AVRT, in which the anterograde is happening through the AV node, but the retrograde is happening through bundle of Kant. So the features, the EKG features will have a regular tachycardia. It will have narrow complex tachycardia, but sometimes will have wide complex tachycardia if the patient is having bundle branch again. Okay, number 3, which is really very important, the rate. Usually the rates are very fast because this pathway is unchecked. There is no regularity mechanism on this accessory pathway. This is a congenital abnormality. So it will be very fast in conduction. So it will give us a heart rate of 200 to 300. Okay, the most important part, if you look here, guys, these 3 features are seen also in AVNRT, in atrioventricular nodal reentry tachycardia. They are all the same, except for the heart rate. In AVNRT, it could be slower than that, 140 to 280, but still there is an overlapping. If a patient heart rate is 210, it could be AVRT or AVNRT, right? So what is actually differentiating to both of them is this one, the long RP interval. Let's talk about this. Okay, let's understand this. So when the electricity is going through the AV node and this impulse goes to the ventricles, this will give us the QRS complex. It should be a narrow complex, not like this. Okay, narrow complex. And after that, the electricity will go back into bundle of Kant, producing retrograde P wave. So the P wave will be after the QRS complex. So now we have RP interval. And this is almost always a prolonged interval, more than 70 milliseconds, which is almost more than 1.5 small squares. Okay, this is very, very important because in the AVNRT, we usually don't see the P wave because it is buried within the QRS complex. And even if you see it, it will be just adjacent to the QRS complex. And the RP interval will be very, 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 very short. Okay, so if you see a P wave just after the R wave, and there is at least 1.5 small squares in between, this is almost an AVRT, orthodromic AVRT. All right, what else? What are the other features that we can see here? Is the QRS, something called rate-related ischemia, because the rates are very high. The patient will have myocardial ischemia and ST segment depression will happen. And also the QRS complex alternance, in which because of the voltage differences between each beat, the QRS complex amplitude will be different each time. And this is also seen in AV and RT, so they are not very specific. The only specific thing is this long RP interval. Okay, let's take an example. Let's look at this EKG. It seems pretty regular, only one large square in between. Okay, one large square in between. And it's narrow complex. Again, narrow complex versus wide complex does not affect the management a lot because, again, if the patient is having bundle branch block, the QRS complex will be by definition wide complex. So this is a narrow complex tachycardia that is regular, and the heart rate is almost 300, less than 300 a little bit, right? Sorry. So this is actually very similar to AV and RT, as we talked in previous videos, right? They have the same features. So how can we tell? Actually, it's very, very, very hard to tell. But let's have a look here. If you look at the QRS complex, there is a small upstroke here. They are small P waves just before the T waves. This is a very clear one. Okay, it's very hard to detect. Only you need, like, you can see it in in few beats. Okay, this is a P wave, and if you look at the P wave to the R wave, it's more than 1.5 small squares. So this is a long RP wave. Okay, this is a long RP wave. So this is this most likely to be orthodromic AVRT. Orthodromic AVRT. Now, fortunately, the treatment is the same. Fortunately, the treatment is the same. AVRT is treated as AVNRT. If the patient is unstable, I will do a DC cardioversion. And if the patient is if the patient is stable, sorry, if the patient is unstable, we always go to that DC cardioversion. But if the patient is stable with normal vitals and he's like awake, everything is okay, we try to give something to block the AV node. Again, why we block the AV node? Because the initiation of this orthodromic AVRT is through the AV node. The AV node first initiated the reentry circuit and the bundle of Kant completed it. Okay, so you have to give something to block the AV node. You have to give something to block the AV node. So you can do vagal maneuver, you can give adenosine, you can give calcium channel blockers or beta blockers. All of them can abort this AVRT. Now, just keep in mind that this patient has an accessory pathway. And because of this accessory pathway, at any time, and this is very important, at any time you are giving a nodal blocking agent, there is a small risk of inducing atrial fibrillation. And the worst scenario on those patients who are having an accessory pathway is to get them into atrial fibrillation. Why? Let's go back to this image here. Okay. Again, the treatment for orthodromic AVRT is nodal blockage. You block the node. So you break the cycle, you break the circuit. Okay, but at any time you are giving a nodal blocking agent, you may induce an atrial fibrillation. What happens in atrial fibrillation? There is a huge firing from the atria. The atria is firing a lot of electricity. And in normal hearts, the AV node will block the excess amount of stimulation and will only allow for a certain amount of the electricity to get to the heart, to the ventricles. But in case of a bundle of Kant, in which there is uncontrolled pathway between the atria and ventricle, all these electrical impulses will go to the ventricle and increase and induce a very, very fast ventricle contraction. And the ventricles will start fibrillating just like the atrium, and the patient will have cardiac arrest and they can die. Okay, so always, if a patient is presenting with AVRT or even AVNRT, because it's sometimes very hard to tell, and you are giving those patients an AV nodal blocking agent, you have to observe the patient to not induce atrial fibrillation after that, because if you induce atrial fibrillation, those patients can go to cardiac arrest. Okay. Now, what about the antidromic AVRT? This is really very rare. It's only 5% of all Wolff-Parkinson-White syndrome. So in all patients with bundle of Kant, only 5% of them will develop AVRT that is antidromic. And again, what is the pathophysiology of antidromic AVRT? It's very simple. It goes through the bundle of Kant first, causing broad complex tachycardia, and goes back to the AV node above there. Okay. Now, it's very easy to detect on EKG, and it will give always a broad complex. It's never complex, because the conduction to the ventricles happens through the accessory pathway, and it's almost always mistaken with a VTAC. Okay, and when you are in doubt, just assume VTAC and treat accordingly. What are the features? The same. It's 200 to 300 beats per minute. It's regular, and it's wide complex, just like this one. You can see it's wide complex. It's almost less than 300, or better 300, because it's like 1 point something of the large square between. So it's like 290, 280. And this is a broad complex because it is more than 3 small squares from here to here. Okay, so it's very, very difficult to distinguish from VTAC. And if you are in doubt anytime, you should pursue a diagnosis of VTAC and treat accordingly. If the patient is unstable, again, we do DC cardioversion. But if the patient is stable, this is very important. We should not target the AV node, because the initiation of this circuit happens through the bundle of Kant. Okay, so you have to block bundle of Kant. You have to block bundle of Kant. So you give amiodarone, or you give brokinamide, which is preferred. This is the first line treatment for this. For any accessory pathway, if you want to stop the accessory pathway, you give class 1 antiarrhythmic, which is brokinamide. Second lines are like class 3 eputylide, maybe amiodarone as well can be used. It's as second options, but they are less effective in establishing revert to normal sinus rhythm. But generally speaking, we give brokinamide. Now, the idea here, we don't block the AV node. Why? Because you are still having a fast conduction through the bundle of Kent. And if you give a AV nodal blocking, you are blocking the AV node, and after that, you may induce atrial fibrillation. And if you induce atrial fibrillation, the bundle of Kent is still happily conducting everything. So all the atrial fibrillation stimulation will go to the ventricles and inducing ventricular fibrillation, and the patient will die because of cardiac arrest. So you have to be careful of that. And that's it. Thank you.